So good morning, everyone. Is my voice audible to everyone? Hello.
Yes, sir.
Yeah. So good morning, everyone, and welcome to the second session of Maharashtra Rheumatology Association PG Training Program, August 2025. So it's a we are privileged to have Vikram sir, who is going to talk on a very complicated topic, Apla syndrome. Sir is a professor of medicine and in charge of rheumatology at HBT Medical College and Cooper Hospital, Mumbai, and he's also visiting consultant rheumatologist at Criticare Hospital, and he's an observer from the South End University Hospital, UK. Sir is also a fellow of Indian College of Physician and FEIMER fellow, reflecting his deep commitment to both clinical excellence and medical education. And Sir has conducted IRA SD Devdar quiz from 2017 to 2022. So, Sir is going to talk about this complicated topic on Apla syndrome. What are the clinical pearls and the various case-based insights on managing the Apla syndrome? So let's begin with Sir.
Yeah, thank you, Deepak, for the kind words of introduction. Uh, Antiphospholipid syndrome and antiphospholipid antibodies are two different things. So, while going through this lecture, we will become more well versed with what these terminologies are and how exactly to interpret and use these terminologies. So the objectives of this session are, at the end of this lecture, all the PGs who are attending this lecture in medicine should be able to define antiphospholipid syndrome, enumerate the clinical features of antiphospholipid syndrome, describe the pathogenesis of antiphospholipid syndrome, enumerate the Sapero classification criteria, be able to describe what is catastrophic APS and which are the conditions, which are the differentials of CAPS, how to treat the cases of antiphospholipid syndrome with case-based discussion, and they should also be able to counsel the patient and the relatives about the clinical condition, its outcome, and what are the treatment measures that are available. Now, when we see the historical aspects, almost 75 years back, an unusual clotting inhibitor was described in patients of SLE, which was later labeled as lupus anticoagulant. Bowie in 1963 described the process of thrombosis, and Johansson et al. Labeled it as a syndrome of recurrent thrombosis associated with a biologically false positive serological test for syphilis and the lupus anticoagulant, which almost share common epitopes and are detected very easily with each other. Nielsen described a spontaneous abortion associated with lupus anticoagulant, and recurrent fetal loss, thrombosis, and lupus anticoagulant was established as a triad in 1980, and therefore Hughes and colleagues who worked on this for almost a decade found that this biologically false positive serum for syphilis is due to the negatively charged anticardiolipin antigen. And that is how Professor Graham Hughes gets the name of this disease called as Hughes syndrome or antiphospholipid syndrome. Now, what exactly is antiphospholipid syndrome? It is an acquired autoimmune thrombophilia which is characterized by vascular thrombosis. There can be recurrent pregnancy loss, thrombocytopenia, and a laboratory evidence for antibodies against the phospholipid binding protein and their cofactors in blood. Now, here I would like to mention that actually this antiphospholipid syndrome is a misnomer because the antibodies are not directed against the phospholipids, but they are directed against the phospholipid binding protein cofactors in blood. Epidemiologically, if we see, if we screen healthy individuals, we can find that 1 to 5% of healthy individuals can have these antiphospholipid antibodies in very low titers, and therefore the presence of antibodies is not synonymous with the presence of clinical syndrome of APS. As the age increases, the titers in these antibodies also increase, and the positivity rate tends to increase to about 7 to 10% beyond 60 years of age. In patients of SLE, about 15 to 34% patients may have lupus anticoagulant. Again, here I would like to mention that this lupus anticoagulant also is a misnomer because it is not found in all the patients of lupus. It is found in patients who have primary antiphospholipid syndrome, and in the labs, it is shown to have anticoagulant effect, whereas actually in patients, it gives rise to the process of thrombosis. So this concept should be clear that lupus anticoagulant also is a misnomer and misleading term, because on one side we get the clinical picture of thrombosis, and on the other hand, it is labeled as lupus anticoagulant. 12 to 44% of patients may have anticardiolipin antibodies. About 20% may have beta 2 GPI antibodies, and all the patients who have these antibodies will not develop the process of thrombosis. Only 20 to 50% of the patients will develop the thrombotic events. These antibodies are also found in certain malignancies like B-cell lymphoma, chronic myeloid leukemia, non-Hodgkin's lymphoma, renal cell carcinoma, breast carcinoma, and adenocarcinoma. And if we study the patients of autoimmune hypothyroidism, there are reports that patients of autoimmune hypothyroidism who do not have thrombosis will still harbor these antibodies. Now, in a study and meta-analysis which was conducted, it has been found that the overall antiphospholipid frequency estimate is almost 6% for the pregnancy morbidity, 14% for stroke, 17% particularly in young stroke, 11% for myocardial infarction, and 10% for deep vein thrombosis. Now, there are various Indian studies which have depicted the prevalence of antiphospholipid syndrome. This slide can be useful for those students who are doing their dissertation in this field. So there are various authors like Makhija, Chandrasekhar, Vora et al., Ramnath Mishra, Dr. Ghosh, and Dr. Singh, who have studied the clinical manifestations of antiphospholipid syndrome. And in various studies, it has been found that it ranges between around 20 to 45% and 50% in certain cases. Now, what are these antiphospholipid antibodies? These are antibodies against the phosphatidylcholine, ethanolamine, serine, and glycerol. Anticardiolipin antibodies. Anticardiolipin antibodies are directed against the diphosphatidyl-glycerol. Antiphospholipid syndrome again is a misnomer. I'm laying stress on this point again because you should remember that these are the antibodies against the protein phospholipid complex and not just the antiphospholipids. Prothrombin and annexin are the other recognized targets in patients who develop the process of thrombosis. Now, there are certain conditions which are positively associated with APLA, and patients may test positive for the antibody but may not develop the clinical syndrome of APS. So, healthy individuals, advancing age, lymphoproliferative diseases we have already enumerated. There are certain infectious diseases like syphilis, malaria, hepatitis, HIV, Lyme's disease, infectious mononucleosis, and not to forget drugs like anti-epileptics, phenytoin sodium, hydralazine, valproate, phenothiazine, procainamide, and chlorpromazine. If patients have taken these medications anytime in the remote past, they may still test positive for the antibodies after almost a decade or even 2 decades, and the antibodies will be present in the blood. Now let us try to simplify the process of pathogenesis of antiphospholipid antibodies. Now, what exactly is the process? Now, it has been proven beyond doubt that there are two theories which are required for the development of thrombosis. Now, in this, the antiphospholipid antibodies, they play a dual role. They act as diagnostic markers so that we can label the patient as suffering from antiphospholipid syndrome. as well as these antibodies act as pathogenic drivers of the antiphospholipid syndrome. Now, what do I mean by that? In the first hit theory, there is endothelial disruption. So during this, there is activation or there is apoptosis of the endothelial cells, platelets, trophoblasts, phosphatidylserine, which is a negatively charged phospholipid, migrates to the cell membrane when there is endothelial activation or there is programmed cell death of these cells, thus circulating the beta-2 GPI, which binds to phosphatidylserine via surface receptors like ApoE2 receptors, annexin-2, or toll-like receptors. We'll see this in the subsequent diagram, so it will be clearer. So there is endothelial cell activation, which is the first hit theory. Now, there will be patients who will have only this first hit theory due to endothelial cell activation due to various reasons like inflammation, diabetes, atherosclerosis, ischemic heart disease, but they may not develop the process of thrombosis unless and until there is a second hit theory in which there should be complement activation, which induces the expression of adhesion molecules, activates monocytes and polymorphs, which release the pro-inflammatory mediators, which ultimately cause the prothrombotic state. There is oxidation-mediated damage to the vascular endothelium via the endothelial nitric oxide synthase, which leads to leukocyte adhesion and the process of thrombosis. Interference or modulation of the phospholipid binding protein is involved in the regulation of the normal coagulation pathway, and thus hampering of this mechanism causes the process of thrombosis. So once again, let us recap what exactly is happening. There is a first hit in which we see that the antiphospholipid antibodies and the beta-2 GPI bind to the endothelium, which is disrupted, or the endothelial cells which are activated. In the subsequent stage, there is release of leukocytes, which release the cytokines and prostaglandins. In the next step, there is formation of these antiphospholipid antibodies and a phospholipid binding protein complex. And in the second hit, when these antibodies combine due to complement activation gives rise to the process of clot formation. So this is, in a very simplified nutshell, what exactly happens during the process of thrombosis. So remember that there is endothelial cell disruption followed by the second hit, and the second hit may occur not necessarily immediately, it may occur with some pause in time. It may occur after a year, 2 years, 5 years, 10 years, nobody knows. And therefore, these antibodies may harbor in the body, but the process of thrombosis may not take place in all the people who are harboring the antibodies. Now you need to know what exactly are the antiphospholipid syndrome Sapiro classification criteria and when do you label a patient as antiphospholipid syndrome. Now, when you have definite APS, there has to be one clinical feature and one lab parameter. So let us first go through what are the clinical criteria. There should be vascular thrombosis, which can be in the arterial tree or the venous tree, and there has to be pregnancy morbidity. Now, what do you mean by pregnancy morbidity? Only a history of abortion is not sufficient. You need to ask the patient whether it is a spontaneous abortion or whether it is induced abortion. If the female has aborted because she does not want the child, do not consider it as pregnancy morbidity. So, what is exactly pregnancy morbidity? One or more than one death of a normal fetus after 10 weeks of gestation, one or more preterm delivery in less than 34 weeks of gestation due to severe eclampsia or placental insufficiency, or three consecutive abortions at less than 10 weeks when other causes are being ruled out. Now, it has been demonstrated in obstetrics that having abortions in healthy individuals is also possible, but they are usually first trimester abortions. So if there is a history of only one first trimester abortion, you immediately need not suspect antiphospholipid syndrome. But if other causes like embryonal and chromosomal abnormalities have been ruled out, torch infection has been ruled out and there have been 3 consecutive abortions, that will be the right time to suspect APS in a female who is having bad obstetric history. What are the laboratory criteria to support the evidence of APS? You should have anti-cardiolipin antibodies, IgG and IgM positivity in moderate to high titers, lupus anticoagulant positivity, and anti-beta 2 glycoprotein 1 IgG or IgM in moderate to high titers. So when the moderate or high titers are present, we consider it as 40 or more than 40 as a cutoff limit. And there is another caveat to this definition. These tests should be repeated 12 weeks apart and should test positive at the end of 12 weeks also. Many a times, people who are working in government institutes will know that due to financial crunch, it may not be possible to repeat it at the end of 12 weeks. But if the clinical criteria and lab criteria are supportive of the diagnosis, you can start the treatment and not wait for 12 weeks to repeat the test. Now, there are certain other clinical features which will be present in cases of antiphospholipid syndrome, which are not going to cause the process of thrombosis. So they are labeled as non-thrombotic features, which should may arise the suspicion of antiphospholipid syndrome. So clinical evidence of livedo reticularis. This is a finding in the skin. I will show it in subsequent pictures. Evidence of unexplained thrombocytopenia, autoimmune hemolytic anemia, cardiac valve disease. Now, what do I mean by cardiac valve disease? Not the rheumatic heart disease, but the patient has got valvulopathy where there is thickening of the valve leaflets. Now, here I would like to share my experience about one case which I had seen about 10 years back. She was a 63-year-old lady who had undergone mitral valve replacement because somebody had done her echo and labeled her as a rheumatic valvular heart disease. On asking her the history about rheumatic fever in the past or taking benzathine penicillin, she denied that and she said she had never experienced any palpitations, breathlessness, heart failure symptoms, or arrhythmias up to the age of 63. And she had undergone the surgery about a year back. While going through her reports, I found out that it was only a valvulopathy. There was not significant mitral regurgitation. The ejection fraction was good, but somehow she had undergone the valve replacement surgery. Her previous reports of 5 years of CBC had revealed there was persistent thrombocytopenia. And after that, I sent her antibodies, which turned out to be positive. So she probably was a case of non-thrombotic APS because there was thrombocytopenia which was unexplained and the cardiac valve leaflets were showing only thickening. There are other CNS conditions like multiple sclerosis-like syndrome. When we have a patient who has got some demyelination features, they may be having involuntary movements like chorea. They can present with transverse myelitis like picture coming with paraplegia or paraparesis, quadruparesis which can mimic GBS, or they may come with unexplained seizures. Unexplained adrenal insufficiency, unexplained nephropathy, unexplained osteonecrosis of the bone when the patient has never received steroids, or unexplained pulmonary hypertension. These are the conditions which should also arouse the suspicion of non-thrombotic APS. And the laboratory evidence to support would be the IgA anti-cardiolipin antibody or IgA anti-beta 2 GPI. Now remember, when we are talking about thrombotic APS, it is IgG and IgM, whereas in non-thrombotic APS, it is the IgA antibody. So unexplained arterial thrombosis, what are the various differentials that you should think about? It could be atherosclerosis, it could be a process of vasculitis, there could be homocystinemia or homocystinuria. Myeloproliferative disorders can cause unexplained thrombosis. Protein C deficiency, protein S deficiency, and antithrombin 3 deficiency are some of the other differentials where there is unexplained arterial thrombosis. And if you have antiphospholipid antibodies negativity, you should evaluate for these conditions. Unexplained venous thrombosis. The commonest one is factor V Leiden, protein C proteinase deficiency, antithrombin 3 deficiency. Nephrotic syndrome can sometimes present with renal vein thrombosis. In the peripartum state, the female can present with cortical venous sinus thrombosis, or there could be thrombosis in the uterine vessels. Patients who are taking estrogen containing oral contraceptives, patients who present with malignancy and unexplained venous thrombosis, that is your Trozos syndrome. Sometimes patients of Behcet syndrome may present with venous thrombosis, and a hemat condition, paroxysmal nocturnal hemoglobinuria, is to be ruled out when there is unexplained venous thrombosis. Now, let us consider what are the clinical features of a typical case of antiphospholipid syndrome. In the cardiovascular system, they can present with myocardial infarction or cardiac valvulopathy, which I already discussed. Over the skin, you should check for livedo reticularis, which is particularly present on the thighs or the lower limbs, unexplained non-healing leg ulcers, digital ischemia, digital gangrene, pyoderma gangrenosum, or superficial skin necrosis. A patient presenting to obstetrics department with recurrent spontaneous abortions, preeclampsia, eclampsia, intrauterine growth retardation, intrauterine fetal death, or placental insufficiency. The patient may present to a neurologist for cerebrovascular accident, which could be either thrombotic or embolic, or may present with a cortical venous sinus thrombosis. Some patients may present with refractory headache, migraine, epilepsy, chorea, or longitudinally extensive transverse myelitis, which can be associated with SLE, or it may be a feature of primary antiphospholipid syndrome. Patients presenting to the ophthalmologist with sudden onset visual loss should be evaluated for retinal arteritis, retinal vein occlusion, ischemic optic neuropathy, and amaurosis fugax, which can be a presentation of a transient ischemic attack. Hemolytic anemias, unexplained thrombocytopenia, thrombotic microangiopathy could be the hemat features, and they may seek consultation from a hematologist. A person presenting to the nephrologist with severe hypertension due to renovascular microangiopathy and acute onset, rapidly progressing renal failure. A patient presenting with pulmonary embolism without any risk factors, young patient, non-smoker, non-bedridden, has not undergone any surgery, so there are no risk factors for DVT or pulmonary embolism. Think of APS in such young cases. Unexplained pulmonary hypertension. Patients may just present with unexplained breathlessness, or they may present with alveolar hemorrhage due to thrombocytopenia. So this is a picture of livedo reticularis. You can see the embalming over the thighs and the anterior aspect of the lower limb. Pregangrenous changes, which if picked up in the earlier stage, would be easier to manage and will not progress to the stage of gangrene. Now, if these patients develop gangrene, they usually have a dry gangrene and it should never be amputated. You should just wait and watch for about 6 to 8 weeks. The patients will have a natural history of uh, shedding off of the affected gangrenous toes. Now, this is another important condition, that is catastrophic antiphospholipid syndrome. It is one of the rheumatological emergencies which can present as multi-organ failure. It can be precipitated by stoppage of anticoagulation, infection, surgical stress, or oral contraceptive pills. The closest differential diagnosis would be septicemia and septic shock, DIC, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, a manifestation of malignancy, vasculitis, not to forget infective endocarditis, because infective endocarditis can be a challenge to diagnose when you don't have full-fledged clinical features. Hyperhomocystinemia, factor V laden mutation, these are some of the closest differentials of catastrophic APS. The treatment will consist of anticoagulation, steroids, IVIG, or plasmapheresis. And now with the availability of different CD20 antibodies like rituximab can be helpful as a life-threatening measure of CAPS. You can use rituximab. Eculizumab, which is not yet available in India but has been reported in various clinical trials from abroad and is also available in the European countries as well as US, can be one of the future medicines which will help in managing CAPS. So there are certain Asherson's criteria for diagnosing and confirming catastrophic APS. So what are these criteria? There should be evidence of involvement of 3 or more organs or systems or tissues simultaneously. The development of these manifestations should occur within a week of each other, and wherever possible, it can be confirmed by histopathological examination of small vessel occlusion in at least one organ or tissue. So if there is a rapidly progressing renal failure, you can do a kidney biopsy and demonstrate small vessel occlusion on histopathology, which is characteristic for catastrophic APS. Laboratory confirmation by presence of lupus anticoagulant, anticardiolipin, or anti-beta 2 GPI will be helpful in the diagnosis of catastrophic APS. Now, when we are having a probable CAPS and when we are having a definitive CAPS. So for definitive CAPS, all the above 4 criteria should be present. For probable CAPS, criteria 2 to 4 should be present, and criteria 1 to 3 or criteria 1 to 4, and if it is criteria 1, 3 and 4, they should be present for more than 1 week but less than a month. So you have to remember that evidence of 3 or more organs simultaneously within a week, confirmation with histopathological diagnosis of small vessel occlusion in the tissue or organ, and a lab evidence of the antibodies. That will help in making the diagnosis of CAPS. So clinically, the patient may present as a stroke, venous sinus thrombosis, paraplegia, sudden onset visual loss. There could be rapidly progressing renal failure, or there could be Budd-Chiari syndrome, acute onset ascites, unexplained. Patient who is pregnant has IUGR, develops eclampsia, placental infarction, and goes into a HELP syndrome. Sometimes it may be challenging to identify CAPS when the gut is involved. The patient may present with acute onset abdominal pain, which gets aggravated after eating food, or sometimes the patient may present with gangrene of the extremities. So how to differentiate TTP and DIC from CAPS? In TTP and DIC, there will be microangiopathic hemolytic anemia. Thrombocytopenia will be a feature in all of them. If you do the serum fibrinogen levels, they will be decreased in DIC, but normal in CAPS and TTP. The fibrinogen degradation product will be normal in CAPS, but increased in the other two conditions. And the anticardiolipin antibody and lupus anticoagulant will test positive only in CAPS, but it will be negative in the other two conditions. Now, based on the different organ involvement, the antiphospholipid syndrome can be classified into various types. Type 1 is retinal or CNS or major organ involvement. Type 2 is arterial thrombosis. Type 3 is venous thrombosis. Type 4 is arterial and venous both. Type 5 is obstetrical APS. And type 6 is asymptomatic people, healthy people with only antibody positivity. So how should you investigate when you are suspecting a case of antiphospholipid syndrome? You should do a CBC and find out whether there is thrombocytopenia and check for the ESR. ESR may be normal in primary APS, but it may be elevated in secondary APS when there is an associated lupus or other conditions like mixed connective tissue disorders. ANA will again be positive if there is an underlying lupus or mixed connective tissue disorder, but it may be negative in primary antiphospholipid syndrome. Anticardiolipin antibody, IgG and IgM, when they test in moderate to severe range, then it should be considered as positive. Mild, weak positive in low titers may not be given much significance in the absence of any clinical features. Lupus anticoagulant will be positive and it will be detected in the serum. beta 2 GPI, IgG, and IgM antibodies. A prothrombin time and INR ratio is necessary because you're going to give anticoagulation to these patients, particularly warfarin, and therefore you need to monitor the prothrombin time and INR. 2D echo is required to find the valvulopathy as well as to see whether the patient is having serositis in cases of lupus related APS. Obstetrics Doppler. So you will ask the pregnant female to undergo the Doppler and check whether there is placental insufficiency, IUGR or IUFD. Now, whenever there are different areas of major organ involvement, you can ask for the relevant CT scans or MRI with arterial or venous angiography. CT is better over MRI over here because you need to find out whether there is a thrombus or not, or whether there is significant occlusion or not. In doing MRI, sometimes it may take a longer time, and if the patient is in renal failure, you may have to do MRI because you don't need to give contrast. So you need to weigh the pros and cons of CT versus MRI, availability, feasibility, financial constraints, and whether the patient has got deranged creatinine and reduced EGFR. Urine examination is very important, as well as fundoscopy when the patient presents with visual loss. Now, after listening to all these theoretical aspects, let us now come to real life cases and how to manage them. So always remember that the term antiphospholipid syndrome is not synonymous with antiphospholipid antibodies. Presence of antiphospholipid antibodies alone in the absence of clinical manifestations does not mandate therapy. If there is triple positivity, that is, your lupus anticoagulant is detected, your beta 2 GPI is detected, and anticardiolipin antibody is also detected. Triple positivity increases the risk of thrombosis and it increases the pregnancy morbidity as well. So let us discuss some real life cases so that it becomes clearer how to manage them in the on day-to-day basis. So this is the first case who was a 24-year-old female referred from a gynecologist in view of recurrent spontaneous abortions. She had 3 abortions at 3 months, 4 months, and 2 months of gestations. She did not have any history of arthritis, oral ulcers, alopecia, photosensitivity, malar rash, or Raynaud's phenomena. There was no history of stroke, pulmonary embolism, DVT in the past. She did not have edema feet, puffiness of face. There was no oliguria. She did not have psychosis, altered sensorium, or muscle weakness or features of neuropathy. This negative history was very important to rule out associated lupus. There was no history of thyroid dysfunction and menstrual history was regular and normal prior to these abortions. On examination, there was nothing significantly found. Her ESR was normal, CRP was negative, TORC screen was negative, ANA was also negative. Her anticardiolipin antibody IgM was 34.5 and IgG was 54.9. Lupus anticoagulant was negative and anti-beta 2 GPI was negative. So here, in spite of having single antibody, we have seen that this patient has had 3 abortions in the past. And because she was an affording patient, these antibodies were repeated after 12 weeks, which were also positive, making this a confirmatory diagnosis of antiphospholipid syndrome. So she was started on aspirin 75 milligrams per day, and during this time she conceived again and was treated with aspirin and enoxaparin 0.5 milligram per kilogram subcutaneously once daily throughout the pregnancy and for 6 weeks after the delivery. She delivered a full-term normal female child of 2.5 kg birth weight. So, with proper therapy and compliance to medication, favorable outcome is possible. Now, in such cases, it is always mandatory to counsel the patient beforehand that anticoagulation is going to be continued during the entire pregnancy and also during the postpartum period in first 6 weeks, because that also is a period where the patient can have hypercoagulation and can develop thrombosis. So such patients should also be counseled that in spite of being on heparin or low molecular weight heparin, the pregnancy outcome cannot be ascertained, because many patients will say that they have taken injections for all these months, still they have had a IUFD or IUGF. So that has to be counseled in the beginning. Now let us consider the second case. She was a 21-year-old female who presented with 2 months of amenorrhea. She was referred for opinion and further management since the gynecologist had already done her workup and found that lupus anticoagulant was positive. So also the IgM and IgG of anticardiolipin antibodies. She had a past history of convulsions and altered sensorium 2 years back, for which she was found to have cortical venous sinus thrombosis. She was treated with low molecular weight heparin and warfarin for 6 months by a neurologist, and after that, she had stopped seeing the neurologist because she had felt completely all right. This was her imaging, which she had saved, which is showing a complete occlusion of the the left transverse sinus. So in this patient, there was a significant past history of venous thrombosis, and so she was treated with a higher dose of enoxaparin, 1 milligram per kilogram twice daily throughout pregnancy, and along with aspirin. Now, in spite of giving this high dose of enoxaparin, she experienced a fetal demise at 6 months of gestation. So poor obstetric outcome is higher in patients who have had past episodes of thrombotic events prior to conception. The third case was an engineer who presented for opinion about planning a pregnancy almost 10 years back in March 2015. She was diagnosed as a case of lupus in 2012, and she was being treated with hydroxychloroquine and prednisolone. Her ANA was positive, 1 in 1000 homogeneous pattern. dsDNA was also positive. Anticardiolipin antibodies, beta 2 GPI, and LSE, lupus anticoagulant, were absent in 2012. In 2013, she married and went to Middle East and then lost to follow-up. In 2014, she conceived and she was receiving hydroxychloroquine and prednisolone, but she had a spontaneous abortion at 3 months of gestation. This time in 2015, when she presented, when she was planning a pregnancy, her antibody profile was repeated, and this time she was found to be IgM and IgG positive in low titers. She was advised to start aspirin and continued on hydroxychloroquine and steroids. In July 2015, she conceived and came with a UPT positivity and had a 6 weeks of gestational sac, which was confirmed by the ultrasound. So she was added on low molecular weight heparin, 0.5 milligram per kilogram subcutaneously daily, and her existing regimen of aspirin, hydroxychloroquine, and steroids was continued. In November 2015, she developed edema feet, a sudden rise in the blood pressure, and her 24 hours urine protein increased to 1.5 gram with an active urinary sediment, and the complements had dropped. So this was clearly suggestive of a lupus flare. Her steroids were stepped up to 1 mg per kg per day. Nifedipine and methyl dopa were added and was being monitored every 15 days. USG had shown an intrauterine growth retardation with oligohydramnios in December 2015. She responded well to the rise in steroid dose. The BP was gradually controlled. So also her lupus was tamed, proteinuria normalized, and the complements reverted back to normal. So at 36 weeks of gestation, there was a planned C-section, and therefore heparin and aspirin were stopped 24 hours and 72 hours prior to the C-section. Accordingly, she underwent a uneventful C-section and delivered a male child of 2.3 kg. So aspirin and heparin was restarted after the surgery, and it was continued till 6 weeks of the postpartum period. So what are the recommendations for treatment that are available for treating the patients of APS? Now there are different categories and different clinical scenarios that the patient will be presenting with. So each and every patient will have a tailor-made treatment. If the patient has antibody positivity but is asymptomatic, at present there is no treatment recommended. If the patient has had episode of venous thrombosis, the patient should be on warfarin. And if it has been a life-threatening venous thrombosis like a CVST or pulmonary embolism, the patient should receive warfarin and the INR should be maintained between 2 to 3. If there is arterial thrombosis, the INR should be maintained between 3 to 4. If there is recurrent thrombosis, along with warfarin, low dose aspirin should also be given. Now, all these conditions I am talking about in younger patients. If they have other comorbid conditions like diabetes, hypertension, ischemic heart disease, and dyslipidemia, appropriate treatment accordingly should be added to this regimen. If there are valve nodules or deformity or valvulopathy, there is no effective treatment which is known. You can just observe and do a screening echo every yearly. Full anticoagulation will be recommended only if the patient has got vegetations or thrombi which are being embolized to different parts of the body. So if there are intracardiac thrombi, then the role of anticoagulation is essential. If the patient has got thrombocytopenia, but the platelet count is more than 50,000, no treatment is recommended. Now let us come to the obstetric patients. Female patients who have had more than one fetal loss or more than 3 pre-embryonic losses, but there is no prior history of thrombosis. Patient has got antiphospholipid antibody positivity, but there is no SLE. Such patients should be treated with prophylaxis of low molecular weight heparin 0.5 mg per kg per day with low dose aspirin 75 milligram throughout pregnancy as well as in the postpartum period. Second scenario is there is one fetal loss or more than 3 pre-embryonic losses. There is no history of thrombosis, but the patient is a secondary APS. She's got SLE and she's having APLA antibodies positivity. Such patients should be treated with prophylactic low molecular weight heparin, low dose aspirin as per the earlier recommendation. Along with this, you need to give prednisolone and hydroxychloroquine for controlling the lupus and ensure the drug compliance. Third scenario is a patient having prior history of thrombosis. Irrespective of whether there is pregnancy loss or not, patient has got antiphospholipid syndrome, but there is no SLE. So again, we are dealing with a primary APS, but here the difference is whether there is pregnancy loss or not, but there is a past history of thrombosis somewhere else in the body. The dose of low molecular weight heparin should be 1.5 milligram per kilogram per day once a day or 1 milligram per kilogram per day twice a day with low dose aspirin throughout the pregnancy and in the postpartum period, and warfarin should be added after 12 weeks. Now remember here, there is a misconception in many of the obstetricians that warfarin should not be given during breastfeeding. This is again a misconception. Warfarin is safe during breastfeeding. So it can be started immediately after delivery, or if the patient is on heparin in the first 6 to 12 weeks, it can be started with an overlap in the last 5 days of patient receiving heparin. Next scenario, the patient has prior thrombosis regardless of pregnancy loss, but it is a secondary APS. Patient has SLE with antiphospholipids. So here again, the regimen will remain as above. Low molecular weight heparin with aspirin throughout pregnancy and in the postpartum period. You need to give prednisolone and hydroxychloroquine in addition to the above regimen. Now, I would like to mention here that the direct oral anticoagulants like your rivaroxaban do not have much role in APS. So here the preferred drug is still warfarin. Various studies have shown that the direct oral anticoagulants may not be able to achieve the required process of anticoagulation, and therefore they should be very cautiously used, or as far as possible there is no compelling indication, they should be avoided. If the patient has got thrombocytopenia and the platelet count is less than 50,000, you need to treat the patient with prednisolone and, if required, IVIG. Catastrophic APS we have already discussed, anticoagulation with steroids, with IVIG, plasmapheresis, and if required, rituximab or eculizumab, but eculizumab is not yet available in India. Only antibody positivity, no thrombosis, no SLE, but the patient is pregnant. Low dose aspirin, 75 milligrams throughout pregnancy. And now latest recommendations are also that hydroxychloroquine has got some protective effect in such patients and can be given because it is safer during pregnancy. So what is the take home message? The term APS is not synonymous with antiphospholipid antibodies. There has to be a first hit theory where there is endothelial disruption, followed by a second hit, which leads to the process of thrombosis. Antiphospholipid syndrome can be primary when it is not associated with any other connective tissue disorder like lupus or MCTD, or it could be secondary when it is associated with lupus or a mixed connective tissue disorder. Catastrophic APS is a life-threatening rheumatological emergency. It needs to be treated aggressively by a teamwork. The patient should preferably be in the ICU, may require dialysis, may require intervention in the form of thrombectomy. So you need to have the interventional radiologist or the interventional neurologist also on board. Interpretation of antiphospholipid antibodies should be done in the clinical setting only. Now, I am re-emphasizing this again and again because we always see patients who are started on medications when they are not required. They are counseled to avoid pregnancies, particularly by the gynecologist. They tell them that no, you, as far as possible, you avoid pregnancies, but that is not true. Only presence of antibodies does not mean anything unless and until they have clinical features related to the APS. So examine and treat the patient clinically and don't just treat the lab report. This is a very important message for the new generation, and use your natural intelligence to treat patients and not the artificial intelligence. You can take help of artificial intelligence to find out whether the diagnosis which you are making or not is based on the current guidelines which have been given to make the diagnosis, but don't leave it to the computer to make the diagnosis for you. So we are all in the state of महाराष्ट्र and महाराष्ट्राचे आराध्य दैवत गणपती बाप्पा आहेत जे आता लवकरच आगमन करतील. सो सगळ्या परीक्षार्थी विद्यार्थ्यांना गणपती बाप्पा तर्फे हार्दिक शुभेच्छा. गणपती बाप्पा मोरया. गॉड ब्लेस यू ऑल. थँक यू.
Thank you, sir, for such a wonderful lecture and very insightful talk. So, do any student want to ask any question? Has any doubt from their clinical round or any ward case about Apla syndrome?
Vikram, I would like to ask one question.
Yeah.
How long do we continue anticoagulation in patients who have had either arterial or venous thrombosis? Once it has been established, APS was positive at that time. Warfarin has been started now 2-3 years. The patient is taking warfarin. There are no further events, and later the ACLA and antibodies come negative. So, how long to continue and when to stop?
Yeah, so this is a very challenging situation. Many a times we always face this. So if it has been a life-threatening situation, like particularly pulmonary embolism, massive pulmonary embolism, and it has been present in the main pulmonary trunk, treatment should be given lifelong. If it was in the main trunk of internal carotid artery or MCA, it should be continued lifelong. Whereas if it is in the perforating branches or smaller branches, or it was a small pulmonary infarct, small lacunar infarct, then after the event, it has to be given for a period of 1 year. And after that, it can be considered stopping. Most of the time, it so happens that before we consider stopping, the patients themselves stop. Of course, there is a risk of developing thrombosis again, but as you said that the antibodies have turned negative, at least a low dose aspirin should be recommended for these patients. They need not take the anticoagulants continuously if it is a small infarct. But again, I would emphasize, if it is a larger vessel, it is for the benefit of the patient that they continue it lifelong, because we see that there is a recurrence if it was a major branch which was involved. So they should be advised to take it lifelong.
Thank you.
Uh, Good morning, sir. I had a doubt. Do you recommend testing for phosphatidylserine and anti-prothrombin antibodies in patients who we are having clinical suspicion of APS but turn out to be negative for the antibodies we routinely screen?
Not in all the cases. If these patients are male patients, then ideally you should screen. But if they are female patients, then usually you need not screen them for these antibodies. You can wait and watch. Sometimes they may be present in low titers. And if you check them in the acute period of thrombosis, they may turn negative. After giving your anticoagulants, you repeat the test after 12 weeks, they may be positive in low titers, because sometimes when you do these tests in the acute setting, they are getting concentrated in the area of thrombosis, and therefore they may be missed from the sera. So you should wait for 12 weeks, repeat the test, but as far as possible, you need not evaluate them extensively for the antibodies that you are mentioning. Antithrombin 3 and protein C, protein S, yes, because amongst these three, antithrombin 3 deficiency is quite common in the Indian population, whereas protein C, protein S is relatively lesser.
Thank you, sir.
So Deepak, I think we can end
Yes,
this
sir.
meeting. Our next
sir.
lecture would be on 28th of September, and the link will be shared to you about 3 to 4 days prior.
So one more question I had.
Yeah.
Yes, Dr. Kunj.
Sir, if a like a 35-year-old female comes to us in a OPD, like she has a history of multiple abortions in the initial first and second trimester, and when we go ahead with the doing the routine antibody test, like all the three, anticardiolipin, glycoprotein, and lupus anticoagulant, and if it comes out to be negative, then should we think about IgA antibody levels, or our IgA levels are mostly with like non-thrombotic
They are,
clinical features?
yeah, IgA are usually with the non-thrombotic features. So if they have first trimester abortions, first try to, if it is possible, like you
Yes.
speak to the treating gynecologist that whenever they abort, if that can be sent for karyotyping, because most of the times you will find that there are chromosomal abnormalities in the first trimester.
Okay. Acha. Okay, so first we need to rule out others and then only go ahead with the IgA antibody levels, not directly.
Yeah, not directly.
Okay. Okay. Thank you.
Okay, sir. We'll end this session, today's scientific session then.
Okay, thank you, Deepak.
Yeah. Thank you, sir.